Hello, my name is Kelly Vesco, and I serve as an advisor for High Reliability Organization and Patient Safety at Ohio Health, a not-for-profit healthcare system based in Columbus, Ohio. Thank you for participating in this activity. The title of my presentation is Root Cause Analysis and Causal Methodologies. Here's the relevant financial relationship disclosure for this presentation. These are the learning objectives that will be covered during this presentation. These are the key abbreviations that will be displayed in this presentation. We will begin with a self-assessment case study that we will revisit at the conclusion of the presentation. The self-assessment is, which of the following is defined as a condition that, if improved or removed, would have prevented an adverse event from occurring? Is it A, failure mode, B, causal factor, C, root cause, or D, risk factor? As mentioned in the prior presentation, when an event occurs, it's really important to have a process in place to appropriately manage the occurrence of the event. Unfortunately, it's not possible to complete an in-depth analysis on every report that gets generated. Therefore, it's important for your organization to have criteria in place to assist in determining the level of analysis that needs performed. Examples of criteria include events with potential for significant harm, events where harm has occurred, events with severe harm, and repeated events. In theory, as you complete and address your largest existing risks for severe patient harm, your RCA case mix should change, allowing more time for analysis of events with lesser harm. The Joint Commission requires a root cause analysis for events that are classified as sentinel events. A sentinel event is defined by Joint Commission as an unexpected occurrence involving death or serious physical or psychological injury or risk thereof. The phrase "or risk thereof" includes any process variation for which a recurrence could carry a significant chance of a serious adverse outcome. Restriction of in-depth analysis to those events with severe outcomes limits the ability to learn from events where lesser harm was experienced, as the causes of serious events are often the same as those with lesser harm. RCAs should be considered for those events with lesser harm that have significant opportunity for improvement or reoccurrence. When an event occurs that meets one of the described criteria, organizations will typically perform a root cause analysis to determine the causal factors of the event. RCA is a structured problem-solving technique utilized to identify the primary cause of an event. It's a retrospective process that provides a concrete way of correcting a problem at hand. The root cause analysis process will reveal what happened and the deficiencies present in standards, procedures, processes, and behaviors that led to the event. An important deliverable of the RCA process is a set of recommended corrective actions to prevent the problem from reoccurring. A structured approach to RCA is necessary to ensure all steps are accomplished in a thorough and timely manner. Actions following a significant event involve caring for the patient's immediate needs, determining the extent of condition, communicating the event to area leadership, reporting the event, and importantly, providing support resources for caregivers who also may be suffering emotionally as a result of the event. Steps 2 through 4 can occur concurrently, especially if leadership can complete the tasks while the care team is assisting with the patient's immediate needs. Above all, the patient's needs should be the primary focus subsequent to an event, and the patient's physician should be notified. Actions like calling a rapid response or code blue should be taken in an emergency. If applicable, protocols to administer a reversal agent like naloxone, for example, should be followed. While the patient is being taken care of, the leader over the area should take action to identify the potential for the same condition to exist somewhere else in the organization and take necessary precautions to prevent a similar event before the RCA can take place. For example, If a pump programming error occurred with insulin, a manager of the nursing unit should round on all patients receiving insulin infusions to ensure that they are correctly programmed and that there's not an issue with the established settings of the smart infusion pump drug library. Next, the leader over the area can assist in ensuring organization protocols are followed to notify risk management and senior leadership of the event's occurrence. They can also assist in preserving any evidence and sequestering malfunctioning equipment. The individual who discovered the event should be encouraged to report the occurrence and share their own narrative about what occurred to the organization's event reporting system. The area leadership should also take steps to discuss the event with the involved staff to begin to determine what took place and if appropriate follow-up was completed. Staff involved in the event will also frequently be upset and impacted by what has occurred and should be offered support via a peer intervention program or higher level, such as a confidential counseling program that might be available. Most of these are commonly referred to as employee assistance programs. This slide includes an example of standard work developed to provide guidance to staff and leadership on what response is required when an event occurs. These are displayed as posters in all care areas and provide resources like an equipment sequester tag that can be placed on a device so that there is a visual indicator for everyone to know that the equipment is not appropriate for use. An algorithm is also available to assist in determining if the event requires escalation to leadership or just completion of an event report. If escalation to leadership is determined, a safety debrief form is completed so that information about the event can be collected while details are still fresh. If the event meets a level of risk the organization deems significant, senior leadership will often request an RCA be performed. Examples of senior leaders that may be involved include the chief nursing officer or director of pharmacy. The senior leader is often accountable to ensure the action plan from the RCA is implemented and assist in addressing barriers present that prevent actions from being adopted. Once the decision is made to conduct the RCA, determining the structure and size of the team is really important. Typical roles include individuals of diverse backgrounds and experiences and subject matter experts. The facilitator of the RCA is the quarterback of the team. Ideally, this individual should have formal training in root cause analysis. The facilitator guides the investigation process, organizes the RCA meeting process, maintains any necessary documents, and provides status updates to leaders of the institution. The unit manager is often included on the RCA team to provide feedback about the culture of the area and provide feedback to staff in their area on what the process is entailing and what the output of action items are. Subject matter experts in the area being examined should also be included. For example, the medication safety officer would be included in any RCA that involves a medication. Risk management often works closely with patient safety teams in reviewing events due to their role in incident claims management. A physician leader is often identified as a co-lead of the analysis and is helpful in providing insight about the clinical details of the case. For example, like if the symptoms experienced by the patient were reasonable considering their clinical status, or if the error was a direct cause of the symptoms or harm that the patient experienced. Staff members from the area are a vital member of the team as they can provide the most accurate perception on what processes are in place, what challenges exist, and what unexpected variation may be present in the area. Involving the staff involved in the event can be controversial, and the decision to include the person should be made on a case-by-case basis. Depending on how the individual has reacted in response to the event, the RCA experience could either further induce trauma as a result of recounting the details of the case, or may, on the other side, help with healing by being part of an improvement process to prevent a similar event from occurring in the future. If the staff member is involved, the team should be notified in advance so that everyone is able to act in a manner that is not being threatening or judgmental. Prior to the initial RCA meeting, the facilitator should investigate the event to confirm details surrounding what occurred. The purpose of the investigation is to find fact, not place fault. Attention should be made to understand the systems and processes that contributed to the event and how the human errors interrelated with those system problems. A background analysis should be completed as a preliminary examination. All materials related to the event should be aggregated, including documentation from the medical record and any contributing equipment involved. Interviews of involved staff should be conducted as soon as possible to preserve immediate memories of the event, and an initial sequence of events or timeline should be constructed in preparation for the first RCA meeting. It's pivotal for the RCA facilitator to conduct a preliminary examination of the event in preparation for the RCA meeting. A background analysis should be performed that identifies the processes involved in the event, who was involved, what the physical setting looked like, and how processes routinely occur when they are successful and free of error. The facilitator should also become familiar with policies and procedures relevant to the event, as well as best practices for the area being examined. For example, for a medication event involving an automated dispensing cabinet, the RCA facilitator might consult ISMP's best practice guidelines for the use of automated dispensing cabinets to assess how the organization's level of adherence in meeting those defined best practices. The preliminary examination of the event should not be driven from your desk. The facilitator needs to go to Gemba, which is that place where the work is being completed, to see systems and processes in action. It is important to interview staff as soon as possible to preserve personal accounts of what occurred. The longer after an event occurs, the likelihood details of the event are lost. It is recommended the interview be held in a setting viewed as non-threatening to the interviewee. To build trust and establish credibility with the individual, the RCA facilitator should describe the purpose of the RCA process as a tool to learn from events in order to create better systems and experiences for not just patients, but also our staff. At the beginning of the interview, staff should be asked open-ended questions that help the individual provide a detailed account of what occurred. Example questions include asking the individual to just simply describe what happened and asking them to expand when you desire further details. It is important to allow individuals to recall everything they can about the event. After the RCA facilitator assesses a satisfactory account has been provided, more pointed questions can be directed to the individual about what occurred, like specific times or words and phrases used in communications. Comprehensive notes should be taken during all interviews, and you may even want to consider using a scribe to assist with the process. Once all information has been collected, the RCA facilitator will develop a sequence of events in preparation for their initial RCA meeting. The sequence of events is a timeline of significant events leading up to the occurrence. RCA training courses often recommend the timeline is constructed starting at the occurrence of the event and then by working backwards. The timeline should express what actually happened, not what was supposed to have occurred. There are various structured methodologies available to construct a sequence of events. A method often used are event and causal factor diagrams. The RCA facilitator should choose the method most comfortable for them. Once the preliminary investigation is complete, the RCA meeting can be held. A typical RCA is completed in 1 to 3 meetings. The 3 primary goals that need to be accomplished in the RCA meetings are 1, to obtain consensus from the team on the exact sequence of events and identify events and actions that deviated from normal operating procedures. Once this is achieved, the team can work on identifying the root causes of the event. Of note, it is rare for an event to have been caused by one single root cause. Typically, there are several root causes. Once the root causes are determined, the team should come up with action plans that aim to prevent reoccurrence of the event. Many organizations open up each RCA meeting by sharing expectations of team members, especially for those that may have never participated in an RCA. The sponsor may share the purpose of a root cause analysis as a process to learn from unanticipated events to improve safety for patients and staff. You may also want to establish a safe word for the team to use in case there's a feeling that maybe a conversation is heading towards being punitive in nature. At our health system, we use the word pineapple. Team members should also be encouraged to direct all questions and comments to the entire group, as collective feedback is essential. As mentioned, the initial task of the RCA team is to finalize the timeline of events and make any necessary modifications. It can be very natural for people to want to jump right to what went wrong or what the root causes were, but it's important to simply establish what occurred as the initial step of the analysis and not jump to identification of deviations and root causes. A parking lot can be created for suggestions about actions or improvements the team can consider during the action planning phase of the RCA. Despite doing a thorough workup and investigation prior to that first RCA meeting, there can be times when the team needs to take a break to seek additional information to insert into that timeline. Depending on the circumstance surrounding the event, the team may also need to travel to the scene of where the event occurred to better understand any pertinent environmental factors that contributed to the event. That exercise or supplemental photos can be useful to provide members improved visibility to what occurred. Once the timeline of the events is agreed upon, the RCA team can next focus efforts to identify elements of the case that deviated from what normally occurs. Deviations are most commonly identified based on the preliminary investigation and the team's feedback. Even if a deviation is not identified, the team should be critical of all elements and consider if a process current state just might be substandard. If it is substandard, then it should be considered a deviation. If a deviation is human in nature, the team should consider if the deviation would have been made by others with a similar level of experience and knowledge. If more than one individual is susceptible to making the same deviation, then there's typically a system breakdown that needs improvement. If other individuals would have been less susceptible to the error, resulting actions might be more focused on directly working with the individual involved to increase their knowledge and skill set. Typically, deviations are given a distinction on the sequence of events timeline so that they can be readily identified, as shown here on the example on this slide, where the deviations are presented as yellow diamonds. Once the deviations have been identified, the team should begin to identify the root cause of each deviation. This can be accomplished by a variety of methods. A common method deployed is using a technique called the 5 whys. The 5 whys technique is used to explore the cause and effect relationship of each deviation. The primary goal is to determine the root cause of the deviation by repeating the question why. Each answer forms the basis of the next question. The 5 in the name derives from an anecdotal observation on the number of times the question why needs to be addressed to identify the root cause. These whys can be considered failure modes in which the deviation manifested. These failure modes are often also referred to as causal factors. There are numerous causal factors that can lead to a deviation. Some common factors include simple human error, communication failures, equipment and technology failures or malfunctions, different environmental factors, ineffective policies or maybe training around policies and procedures, and various structural cultural factors. This is an example of what a cause and effect diagram might look like when the causal factors are added in after utilizing the 5 whys technique. The RCA team will arrive at identifying the root cause when they identify a causal factor that, if corrected, would have prevented the event from occurring. A true root cause must have a confirmed cause and effect relationship. If changing the factor might have prevented the event, then it's not a true root cause. Again, the majority of events will have more than one root cause. After the root causes are identified, statements should be crafted that clearly describe the cause and effect relationship of the root cause in the event. For example, rather than stating that a physician made an insulin dosing error that led to harm, the cause should be included before the effect. So a more appropriate statement here could be to state that due to the lack of an alerting software to check for dosing limits, there was a likelihood of this dosing error, which resulted in 3 times the appropriate level of insulin being ordered for a patient. Once the root causes are identified, the RCA team should next turn their efforts into development of an action plan to prevent the recurrence of the event. It's helpful to assign a responsible individual for each action item, and the senior leader assigned to support the team typically assists in establishing organizational priority around the action items and resource allocations that might be needed. The team typically sets targeted completion dates for action items, and the RCA facilitator will work to track the completion and closure of those items. In order to assess if actions are successful and working, the team may also develop outcome or process measures to track progress and conduct a continued follow-up assessment for several months to determine if the strategies are working as designed. Featured here are examples of mitigation strategies that can be selected by the RCA team. I personally like to display this slide during the action planning phase of an RCA, so the team can ensure we develop an action plan that features high leverage strategies, which we layer then to gain maximum effect on preventing the error that we are reviewing. While root cause analysis is an excellent retrospective analysis methodology, there are additional tools or methodologies that can be utilized to evaluate risks present in your organization. An apparent cause analysis, or ACA, is a limited investigation of an event that has 2 purposes. 1, to identify actions to address a problem and collect event information that aids in the identification of organizational trends. Some refer to ACA as a mini RCA, but many quality improvement purists don't like the term mini RCA. ACA is a format that gives structure to learning and understanding about an event and facilitates the development of an action plan to prevent reoccurrence. ACAs typically focus on events that result in no harm or those considered near miss events. Root cause analyses are expansive and they require a lot of time and resources, and ACAs are less resource intense and can be used as an expedited methodology to understand an event and opportunities for improvement. ACAs can be completed by individuals trained in the methodology and typically are completed outside of meetings, but findings are often shared with an accountable body like your organization's patient safety committee. During the course of an ACA, you may find that potentially RCA would have been a better way to work through the analysis of the event. And if that is found to be true, you can definitely flip from an ACA and vetting the event through your RCA process. Featured here are the typical steps of an ACA that would be completed by a facilitator. Similar to other analysis methodologies, the initial step of the process would be to investigate the sequence or what occurred that led to the event. The next step is to develop a narrative of the problem that occurred that summarizes the event, how it impacted the patient, and the discovered problem. Then the overall extent of condition is determined to assess if the identified problem is an isolated incident, if it's a commonly occurring local problem, or a problem that is global across the organization. Short-term actions taken to improve the problem are noted, and causal factors that led to the event are identified. Similar to an RCA, an apparent cause statement is generated that clearly describes the cause and effect relationship. And lastly, mitigation strategies are proposed to lessen the reoccurrence of a similar event. There are a few approaches that I've seen for using apparent cause analysis. Some organizations hold ACA meetings where they quickly huddle around an issue and, similar to an RCA team, validate details of an event, identify the causal factors, and then develop an action plan. I've also seen some organizations as a policy require an ACA be completed with events where patients have experienced harm, but maybe leadership has determined that an RCA is not necessary. So for example, your organization may have a policy that an apparent cause analysis be completed on all NCC MERP Category E events. I thought it would be helpful to provide an example of what a typical apparent cause analysis format or write-up might look like by going through a case example. So here's the description of our event. So BB is a 7-year-old female who came to the ED with nausea, vomiting, and abdominal distension. She was admitted to the surgery service with a diagnosis of severe small bowel obstruction. The surgery intern prescribed ciprofloxacin, 400 milligrams IV piggyback twice a day. BB has multiple drug allergies, including levofloxacin, which caused a rash. This allergy was documented in the electronic health record. The nurse in the ED retrieved the first dose of the antibiotic out of the automated dispensing cabinet and gave it to BB. Later in the morning, BB developed a rash and hypotension, and it was discovered that she had received a dose of ciprofloxacin despite her known allergy to levofloxacin. She was transferred to a critical care unit, had to be fluid resuscitated, and required doses of diphenhydramine and dexamethasone. So if you're going to do an apparent cause analysis on this case, you would next want to develop your apparent cause statement and list of causal factors. And through your investigation of this case, you find that the physician wrote for an antibiotic to which the patient had a known allergy for, and that medications in the emergency department are available from a non-profiled automated dispensing cabinet, which allowed for dispensing prior to pharmacy reviewing the order, leading to a potential for error, and that the nurse gave the antibiotic without checking the patient's allergies or without realizing the potential for some cross-sensitivity between levofloxacin and ciprofloxacin. The significance to the patient was that she required increased monitoring, fluid resuscitation, diphenhydramine, dexamethasone, and transferred to an increased level of care. You assess that other patients are at risk for a similar error because since medications may be accessed from the ADC prior to them being reviewed by pharmacy. Next, the corrective actions are then determined, which in this case is for all medications in the emergency department to be moved into a profiled automated dispensing cabinet that would require a pharmacist to review the orders, allowing for an appropriate allergy check to occur prior to dispensing and administration. In addition, other areas of the hospital in which pharmacy screening does not occur will also be considered for the same system fix or corrective action. Again, our apparent cause analysis is a concise way or format to summarize an issue, outline the causal factors, and list your improvement actions. Typically, this is all documented on one sheet of paper in length. While it's beneficial to identify root causes and process gaps for single events, using something called common cause analysis to examine multiple events allows an organization to identify the depth of system vulnerabilities. Common cause analysis is also referred to as aggregate root cause analysis in the literature. CCA can be a useful methodology for examining repeat events or for understanding where risk resides in your organization. For example, you might want to proactively consider performing a common cause of your reported anticoagulant events in response to Joint Commission's Sentinel Event Alert on the safe use of anticoagulants. That could help inform you or understand where current risk resides in your organization related to anticoagulant therapy. Common cause can be a form of retrospective and prospective analysis in a sense. The first step of the common cause analysis process is to aggregate all of the event information into a spreadsheet or some form of database. The elements related to the events are then filed. Typical elements that are recorded for medications include the event type, a brief description. I typically try to keep this brief. For example, for an event where maybe a night shift nurse gave an incorrect dose of a medication after getting it from an ADC via override, I might type in my description something like, night nurse gave wrong dose after ADC override as my description. Other elements typically captured as part of a CCA include the medication name, role of the associate that made the error, the phase of the medication use process, the activity being performed. So example here could be like tablet splitting or pump programming, and the human error type, such as a slip, lapse, or knowledge-based error. For medication-based common cause analyses, I personally also like to capture what system-based cause was experienced based on ISMP's 10 key elements of medication use and other common contributing factors like incorrect patient weight. Depending on the rigor of your CCA, you may even collect very detailed information like the time of the event or the unit where it occurred. What I really like about Common Cause is that you can tailor the elements you collect to meet the aim of what you want to examine. As I mentioned, when performing medication-related common cause analyses, I'll record the applicable ISMP key element based on those included on ISMP's Assess Error tool. We also, over time, have developed our own list of common contributing factors we've seen in our organization that are featured here on this slide, and I'll record those as well as part of my analysis. Once all of the event information is aggregated, data can be analyzed to identify the most commonly occurring events and causal factors of the issue that you're looking at. Then an action plan can be developed and prioritized based on your findings. Pictured here are two examples of output from a common cause analysis. The picture on the left is from a common cause analysis I did on medication reconciliation that indicated most of the events reported were associated with the administration process as opposed to the transfer or discharge reconciliation process, and that the majority of events that were reported in our system involved good catches made by pharmacy when reviewing admission orders. The example on the right is a common cause I did on of the time of event occurrence that I performed for a manager who wanted to review the time when events occurred against their staff coverage to work on scheduling improvements. We also perform a CCA annually on our reported lookalike soundalike events to determine if we need to make any modifications to our lookalike soundalike drug list and what prevention strategies for mix-ups that we have in place. All right, we are nearing the end of this presentation, and as I said at the beginning, we would be revisiting this self-assessment question. So the question is, which of the following is defined as a condition that, if improved or removed, would have prevented an adverse event from occurring? Is it A, failure mode, B, causal factor, C, root cause, or D, risk factor? If you determine your response to be C, root cause, you are correct. The root cause, as a reminder, is a causal factor that, if corrected, would have prevented the event from occurring. In conclusion, root cause analysis provides a structured process to learn from adverse events in order to create better systems for patients and staff, and the Joint Commission requires organizations conduct an RCA for events that are classified as sentinel events. If you're looking for additional resources on RCA, I encourage you to seek out the Institute for Healthcare Improvement, or IHI's, RCA2 guidelines that feature best practices around RCAs and guidelines to help health professionals standardize their RCA process and approach and better improve the way they investigate events. These are the references used in this presentation. Thank you for your time and participation.